Good evening friends. This video is in continuation of part 2 video where we demonstrated use the surgery for the longitudinal vaginal septum. The given slide shows you the anomaly with which we are dealing. So we have cut the vaginal septum. Now we have come to the cervical septum. Regarding cervical septum, the important things to be kept in mind is confirm it is a septate cervix. We have told you in the last video the differentiating points between the septate cervix and a double cervix. I usually don't cut the cervical septum. One more important thing I would like to tell you. Intrauterine septum is V-shaped. The thinnest part is at or near the internal os. The cervical septum is inverted V, thickest at the external os and thinnest at or near the internal os. We usually post the patient in the immediate post-menstrual period. We don't usually give tab misoprostol as we use mini resectoscope 18.5 range bipolar resectoscope with Collins knife, the electrode. We usually start the procedure. I usually start the septum incision, intrauterine septum incision from the right cavity. But before that, you should do again a diagnostic hysteroscopy. Why? To know the site of incision. Now the site of incision is very important to mark before starting the surgery. So that's why a diagnostic hysteroscopy is done. I usually choose the right cavity as I am comfortable in the right cavity. It is not hard and fast that you should only go from the right cavity. You can go it from the left cavity also. So I start doing a diagnostic hysteroscopy to mark the site of incision. Now how to know the site of incision? Firstly, if your sonologist is good enough, he should be able to tell you the length of the septum, the thickest part of the septum, the location, and the thinnest part of the septum and its location. Usually the thinnest part is at or near the internal os. So I do a diagnostic hysteroscopy to mark the site of incision, and this picture shows you that you can see the striations also, and that is the internal os. Just above the internal os, I go 1.5 cm and start cutting the intervening wall from the right cavity. The other thing is that when you do a diagnostic hysteroscopy, you could see white striations with a sign of fusion of the uterus. The intervening wall failed to resolve or dissolve. So this could be one of the signs where you can start the taking incision. So I usually start taking incision 1.5 cm above the internal os. So identification of the internal os is very important. So we start with the surgery. Before that, in the contralateral cavity, I usually insert a pediatric Foley's, inflate with 2 ml or 3 ml normal saline, and then we usually proceed with 18.5 range bipolar resectoscope and a Collins knife. A diagnostic hysteroscopy is done initially. As I told you, this is a diagnostic hysteroscopy, and first of all, internal os you should be able to diagnose, and that's the site of incision just above the internal os. I usually use the right cavity because I find it very easy. Here the site of incision is marked and I am cutting with the Collins knife. The Foley's is kept in place, so when we open the cavity, the intervening wall is cut, and when we enter the contralateral cavity, we should be able to diagnose that we have entered the cavity. So that diagnosis is done by the presence of Foley's. Also, the Foley's also prevent the fluid coming out from the other cervical canal, and the distension is also maintained. So I am cutting the intervening wall, and here I have opened the cavity. I think we should be able to see the Foley's. So the Collins knife is usually 2 to 3 millimeter. There we open the cavity. You can see the Foley's also. Now we start cutting the septum. And remember, while cutting the septum, you should be able to keep your eye on both the ostia. Go in the center of the septum. Whenever you are in doubt, retract towards the internal os. Watch the septum. Watch the ostia, and then you start cutting. Don't be in a hurry to cut. It is always better to undercut the septum rather than overcut the septum. Don't start doing heroic things. Always remember, undercutting of the septum is better than the overcutting. This is the right ostia. Always keep my eyes on the ostia. I retract my telescope, I see the ostia and then go on cutting. Usually in a septum surgery, we post for a relook hysteroscopy 6 weeks after the primary surgery. So here's we just touching the septum and pressing the pedal. Normal saline is used as a distension media. The pressure, we start with 80 mm of mercury, and if need arises, we can go till 100 mm of mercury. So at the end of the procedure, without the current, we just push the septal tissue. Sometimes it gets retracted because of the pressure of the fluid, no need to cut. So we are at the end point. I am pushing with the Collins knife. Try to use minimal current as you go towards the fundus. Try to do cold dissection, that is without the current. So both the ostia are same, and I think I have completed the septal surgery. Now, this is a very important. The finally last 1 to 1.5 centimeters of remaining intervening wall between above the internal os is cut. Foley's catheter is stuck against the internal os to maintain the distension. So I am cutting the proximal part of the septum which is near the internal os. Now how do you know you have cut you're near the internal os? First, you can visualize the internal os. Secondly, from the opening you should be able to see the contralateral, that is left cavity lateral wall. If you see that properly, that means you are done. This is lateral wall I am able to see properly. So I think I have completed the surgery. So Foley's is inserted to prevent adhesions. And here we finish off the surgery. Thank you very much.